and mandibular modelling is part of this pathological process. As this occurs, of course, we only have so much face. So the longer the face is, the narrower it's going to be and the shallower it's going to be. It's going to be constricted, reducing the cross-sectional area, which is reducing space for the teeth, leading to dental crowding, and also it's pushing the tongue back down into the airway. We take this image we used earlier on. This maxilla has dropped back down centimetres, and that's going to push the tongue down into the airway. When that happens, there's certain postural compensations you can make to correct the tongue going down into the airway. However, a face that isn't the right shape isn't going to function correctly. Malocclusion is only going to be one of a multitude of different symptoms. And these are all symptoms of what's going on. Of course, the next big symptom that seems to be hitting the headlines is sleep apnea. But from my time in the ENT departments, when I was doing my orthodontic training, the children being treated in ENT departments are the same children we're treating in orthodontists. We're just looking at different symptoms. And the interesting point is all of these different problems seem to have no etiology and are treated symptomatically. But if you grow vertically, you are going to have a smaller airway than if you go horizontally. And when you consider Porcel's law suggests the resistance is related to the power of 4 of the diameter, then you realize how much difference that airway is to breathe through than that airway. Now, I mentioned we can make some compensations to correct for this airway. The compensations we correct is you can either move your head and neck to create space, or you can reposition your mandible and tongue. Now, an interesting piece of research done by Peter Vig, interestingly demonstrated by Hillary Clinton here, is that what he did was he placed a swimming clip on people's noses. This caused people to have to breathe out of their mouth. The first thing they did was they dropped their tongue, opened their mouth. They then tip their head back, because if you do open your mouth widely, it feels vaguely uncomfortable here. So the initial response was to open their mouth, secondary response to tip their head back, and after a delay, after a period, as Marcotte noticed, they wanted to have their heads upright. So after a delay, they then did eh. So it was 1, ho, ho. And then, as a physiotherapist will notice, the trapezius needs to be in a plane, in a flat plane. So your shoulders need to come across. So you have gone from here to here. Now, it doesn't matter where the nasal obstruction is, whether the nasal obstruction's in the nasal airway, whether the obstruction was the nose, whether it's in the pharyngeal airway, the same effect occurs. Now, we talk about the different positions you can place your tongue. You can place your tongue between the teeth, and then as the maxilla mandible drops down, you gain a class 1 malocclusion. You balance both the upper and lower jaw. You can place your tongue forward, which is particularly common of the Caucasian races, which you will get a class 2 division 2. you can place your tongue into your mandible and hold it forward, which is particularly popular with the races of Mongolian descent. Each of these methods is getting volume out of your airway by replacing your tongue. And that will cause a class 3 and maxillary collapse. You can push your tongue forward, as is common in the Negro races, which tends to be called an anterior open bite. Of course, they're making a distinct difference here with bimaxillary protrusion, which is what you notice in the Negro populations. That I'm saying that this is ideal and this is bimaxillary protrusion. Whether this is ideal and this is normal, this is ideal, this is bimaxillary protrusion. So from normal, you understand and you think in a different way. Then we have bilateral posterior open bite. Well, this is a condition that is not well recognized. People accept they see an anterior open bite. They accept they see a unilateral posterior open bite. But very few people have this concept of a bilateral posterior open bite. Most people would call this condition a deep bite. That depends where you ask someone to bite together to take your records. Asking someone to bite together is you dictating how you're going to record them, not them dictating. One thing you notice about deep bite individuals is a large freeway space. Most of these individuals rest with a class 1 level of overlap, a normal overbite. It's only when you ask them to bite together that they go into this deep bite. So, we could ask where we're growing. We're definitely growing downwards. This is a Mesolithic skull overlaid a modern temp. And we've even had to move the modern temp, modern normal to accommodate for the position of the ancient skull. Of course, one you've noticed is those incisors have dropped back and down. And I think that you could probably, my estimation is, you could probably get about 10 millimeters of backward downward growth before you get any level of malocclusion. And if you look at Bjork, who sourced his sample of norms from the army recruits, without overt malocclusion, well, they probably had up to 10 millimeters of downward and backward growth, and they would have still fitted in to Bjork's sample as not displaying overt malocclusion. The most interesting thing on this slide is the position of those molars. The common intermolar width is something in the region of 30 to 35 millimeters. Well, nearly all Neolithic or Paleolithic man had an intermolar width in the region of 54 millimeters. So if, as much as your incisors have dropped back, your molars will have dropped back more. And that's really apparent on the tracing of these molars. And when we're using our molars to decide if we're angles class 1 or angles class 2 or the position, as if it would give us some idea of the bony base underneath, we must remember where we were for 210,000 years over here. And this is a modern aberration. But of course, we have this thinking, this class 1's in the middle, class 3's back or one way and class 2's the other way. And that's what the thinking gains us from using our modern cephalometric norms, our norms. Well, if we change our norms and we change to an ideal, it gives us a very different concept. It gives us a concept where we're dropping down to class 1, we're dropping down to class 2, we're dropping down to class 3, and a very different pattern of thinking, a very different way of looking at the world. This is Waddington's epigenetic pathway. This is a concept whereas Waddington described time dictating on your epigenetic landscape what disease you got. I'm suggesting time is this vertical increase. As that vertical increases, as you drop back, as you make more compensations to maintain a comfortable airway, the ball rolls further down this landscape. And depending on your particular landscape, it will reflect on the type of malocclusion you particularly get. Now, when we are all stuck down here somewhere, we only can see what we see right now. We assume the environment we're living in is normal. It is anything but normal. Nothing around most people, most of the time, was not conceived in the mind of man. Everything around me now was conceived within men, from my suit to the roof over my head, was built by people. We don't live in a normal environment, so we can't see people up like this. If we had half our patients coming in like this, we would understand, but we don't. And this is the progression down into the various different phenotypical expressions of malocclusion. In a way, it's like if we overfed everyone. If we overfed everyone, we would see everyone becoming a little bit fatter, but some people becoming grossly fatter, and some people actually staying just as thin as they were in the first place. A few of them, which is what we're seeing now in modern society, particularly in some of the more advanced westernized societies, but we would turn around and say obesity is genetic. Obesity is clearly the environment. Now, treatment. What treatment can we provide for these individuals? Well, I think on my duty to stay on time with this lecture, I'm going to break there for a moment, and we'll put this in another package. One thing I was asked at the Indian Orthodontic Conference was to show a few cases. And I'd like to show a few cases, and I'd like to go through roughly what I'm doing within my treatment, but I don't want to go over an hour. And I think we'll make another session that goes over that. I want to thank you very much for listening to me, and I want to make you aware that we need to think. The treatment I'm going to present isn't an easy treatment. It may not be the best form of treatment, but as doctors we need to be treating the causes of the problem. We don't need, well, are we just going to straighten teeth? Are we going to just sell a product on its benefits? Are we going to sell something that's just a temporary correction that we have to maintain, or the individual has to maintain? I don't know. I don't know if I have all the answers, but I know that I'm asking the right questions. And in the meantime, please do join me on the Facebook page, Orthodontics, where I'm discussing these issues, where you can ask a question, and where we can debate important concepts such as these. Thank you very much.